We're trying this out for the first time. We've done the series for a while.
Sorry, I don't have a good response to your very good question. No, you could say everything you better. Okay. Ready? Okay. All right, welcome everybody to another lecture for the Chaz Davis Lectureship Series. We're really excited to introduce Erika Crable. She is an assistant professor in the Department of Psychiatry at the University of California, San Diego. She received her PhD in Health Services Research from Boston University School of Public Health. At BU, Erika was also a research fellow at the Evans Center for Implementation Science. So as a health services researcher and implementation scientist, her research focuses on implementation processes and strategies aimed at improving the use of evidence in policymaking. She also tests strategies to promote access to evidence-based substance use treatment services for safety net and justice-involved populations. Prior to her doctoral work, Erika was a research leader for IBM Watson Health, which was formerly Truven Health Analytics. For those of you who know Truven, they do a lot in the substance use disorder space. And in that capacity, she consulted with a variety of federal agencies, including the Centers for Medicare and Medicaid, Substance Abuse and Mental Health Services Research, SAMHSA, and the Assistant Secretary for Planning and Evaluation, ASPE. So these, for those of us in the health policy field, these are like the major health policy agencies. And so I can imagine that was an incredibly useful experience, especially in your role now. So her research has been published in many journals, including Implementation Science, Health Affairs, AIDS and Behavior, Administration and Policy, and Mental Health Services Research. So with that, please join me in welcoming Erika Crable.
Hi, everybody. Good afternoon. Thanks so much. Just want to start by saying thank you for making time to come to this discussion today. I'm excited to hear your thoughts and feedback, and it's an honor to be here at University of Chicago. And also in the Davis Lecture Series. I've been a big fan of this series for a while now, and I wanted to pick up on a thread that Dr. Shapiro mentioned last week in his presentation, right? He started his talk by asking, why haven't we been able to pull the policy levers that solve our stickiest problems in healthcare? And he argued that various actors, including corporations, scientists, government agencies, they all sort of stand in the way in different capacities for preventing equitable, efficient, effective healthcare systems. And then Dr. Grogan very poignantly asked, this is a big problem, so where do we start addressing these issues? How do we start reforming our institutions and our approaches? And so I'm excited to talk to you today because I think that the field of dissemination and implementation science might be able to provide a very useful approach to starting to address some of these sticky problems that we're wrestling with. We can use it to understand the dynamic relationships between these different diverse actors, their priorities, their competing demands, and we can use it to even test out strategies that promote greater alignment between these actors and their priorities. And so I'll talk a little bit more about that in more concrete terms throughout this talk today. So before I get into the talk, I want to take a second to address a few acknowledgements. My work is funded through the National Institute on Drug Abuse, and I have fellowships from NIDA and as well. And then, science is a team sport, so I want to acknowledge the fantastic mentorship that I get on my Career Development Award, including from Dr. Colleen Grogan here at University of Chicago. And then finally, I'll just mention that I don't have the resources to make these slides 508 compliant, at least before this talk, but if folks would like an alternative version of this that is more visible, please let me know, and I'll try to do my best for that. Okay, so I thought I'd give you a little bit of a roadmap for our discussion today. I'd like to start by providing an overview of what dissemination and implementation science are and how it might relate to public policy, which might be more familiar to a lot of folks in this room. And then I want to try and convince you that the research to policy gap is a really big problem for our health systems and our population health outcomes. But as researchers, I think we're also well poised to solve this problem. And you might already agree with this. I've had a lot of really great conversations with faculty and students in your department. And if you already agree with this, which I think you might, this will be really easy and we'll breeze right through it. And then I want to get concrete and describe a really sticky problem created by this research to policy gap. So sometimes we have really good evidence for something or a healthcare service, and then policies, no matter how well intentioned, they might be implemented poorly. So we still run into issues with ensuring equitable access to healthcare services, and access to medications for opioid use disorder within the Medicaid population is a great example of this sticky problem. And then we'll wrap up by talking through a dissemination science study and process that I'm leading that aims to address this issue of improving equitable access to evidence-based medications for opioid use disorder by changing how policymakers think about these medications. Okay. So what is dissemination and implementation science? Well, it's an interdisciplinary field, and I think folks in the room have varying levels of familiarity and experience using dissemination and implementation science approaches. So some of this might be a review. But D&I, dissemination and implementation science, it's rooted in evidence-based medicine. So there's a very common adage that on average it takes about 17 years for evidence-based practices that we know are effective to actually become routinized in our healthcare systems. And implementation science essentially seeks to speed up this process by identifying multi-level implementation strategies and mechanisms that can jumpstart adoption, implementation, and ultimately sustainment of evidence-based practices. And so D&I as a field or a subfield of health services research has really focused on individual level and organizational level implementation efforts to date, but I think it could really do wonders to support the creation and implementation of evidence-informed policy. But sadly, the knowledge exchange between the D&I subfield and public administration and political science has been a little more minimal. But this is not for lack of trying. Political scientists, public administration researchers, folks in this room have been telling public health researchers and implementation scientists, what are you guys doing? Where's the policy, right? There's no shortage of these articles calling on public health scientists and implementation scientists to go beyond measuring the impact of a policy on health outcomes and intentionally examine how policy and politics influence the delivery of our healthcare services. So I want to think about ways that our two fields can find some common ground. So we'll start with some definitions, just to make sure we're all using the same lingo. So dissemination science, NIH sort of commonly defines this as the scientific study of targeted distribution of information and intervention materials to specific public health or clinical practice audiences. And at the policy level, we could really think about using dissemination science to examine the processes by which research is spread and used by policymakers to inform their decision making, right? We could use it to understand how policymakers receive, solicit, and use information about our scientific endeavors that we look through. We can also think about testing and designing and tailoring dissemination strategies to help researchers more effectively communicate their findings in ways that are meaningful, timely, and interpretable for policy actors at any level. And this way, we can really be ensuring that our public policies are informed by the best scientific evidence available. And that scientific evidence, right, we know that there's kind of a misnomer of evidence-based policy. Policy is informed by a lot of things. Evidence is one of those things. But we can think about how dissemination strategies might help to cut through the noise of other interests, like religious beliefs or misinformation or special interest groups that might be at odds with population health needs. So implementation science then is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions. But again, if we apply a policy lens, I think this could really be thinking about how evidence-informed policies are implemented and designing and testing implementation strategies to help implement these evidence-informed policies, or maybe even de-implement policies that are harmful or promote health inequities. Okay. So policy-focused dissemination and implementation science to date has been primarily observational, and it's done a good job of documenting policy actor preferences for research or observing implementation strategies that policy actors use to implement their policies. But wouldn't it be cool if we saw a little bit more testing of dissemination strategies or implementation strategies that aim to achieve policy change? I think that would be really cool. That's kind of where my work is headed. And I'll highlight that this is what NIDA is looking for as well, right? They just released their strategic plan, and their fourth priority area is studying the implementation of evidence-based strategies to promote evidence-based health policies. That's pretty cool, and certainly a change in focus for them. So now that we have a bit of lingo about what D&I science as a field is, I want to talk about how it could be a useful approach to addressing the research to policy gap, which I would argue is detrimental to our health systems and population and individual health outcomes. So the failure to translate research findings into policy is dangerous, right? Low-value health services tend to proliferate under non-evidence-based policies. So we see a lot of unnecessary scans, tests, inappropriate prescribing practices, and approximately 30% of the healthcare provided in the US is low-value care. We could do better. But when research takes a backseat in the policy-making process, we also end up with harmful policies that negatively impact population health outcomes. So a sad example is laws that ban the provision of gender-affirming care, right? These are non-evidence-informed laws. And these bans on gender-affirming care are associated with increases in depression and suicidality for individuals who are seeking those services, especially youths. And when the substance use treatment system is dominated by policies and practices that promote non-evidence-based care, like abstinence only without other options for treatment, we see individuals with substance use disorders downplay their substance use behaviors, downplay their need for care, delay treatment seeking, and ultimately disengage from healthcare system altogether. So the research to policy gap is a big deal, and it has implications on all levels. But why does it persist? And while I don't think researchers are entirely to blame for this, I do think that we're well positioned to solve this issue because we contribute to a lot of the problem, right? So one of the criticisms that researchers get from policymakers is that the studies we pursue have little relevance to real life problems. Our findings could be overshadowed by political or special interest groups, so we're not doing a good job communicating it, often because we have weak dissemination plans. And when we do disseminate, we tend to use language that is inaccessible, lots of jargon, lots of acronyms, right? There's no shortage of acronyms. And we report values that might not be useful to the policymaker. So I hear a lot of the time, hey, I don't need more information that a practice is effective. I need more information about the costing of it and the cost effectiveness of it. But that said, there is a lot of high value research that still fails to make population level impact because it's not reaching policymakers. And so there's a lot of research on that. Some of the known barriers to this are a lack of available relevant research to policymaker needs, policymakers' skills or capacity to act on the research that they're given and really interpret it and synthesize it in a way that's meaningful to their work, the timing of it. Again, outcomes misalignment. We report on one thing when they really need information on another. Lack of managerial support for bringing research into the policymaking process. Staff turnover, folks, leaving who have expertise. And then also a perceived bias that research might be advocacy driven or have some sort of political gain here. But we also have some facilitators that we could build on. We know that when researchers are in the policy networks of policymakers, that builds trust, that builds collaborations, right? So where does this leave us? I'm going to argue that I think we should be designing dissemination strategies that can effectively deliver research findings to policymakers at all levels when they need the information, delivered in a way that's useful and aligned with the outcomes that they need to make decisions about. But in order to do this, we can't just show up when they're making these decisions. We have to develop trusting relationships between researchers and policymakers. And hopefully, maybe ultimately, we could get to a place where researchers are helping design implementation strategies that support policy implementation success. Okay, so I want to talk about this issue using a really concrete example. So we have medications for opioid use disorder that are effective. There's a lot of research on this, that's not debated. But there are still problems accessing these medications. And a lot of these problems stem from policy decisions. So I think it's probably no shock to folks in this room, the US is still experiencing over a decade-long opioid epidemic, right? And drug overdose deaths in the US have increased 30% during the early years of COVID and 15% in 2021 alone. We're losing our family members and our neighbors. Currently, around 5.6 million Americans have a diagnosed opioid use disorder. That's 2% of our entire US population. That's huge. But we also know that there's massive underdiagnosis and underreporting of substance use disorders and opioid use disorders specifically. Interestingly, this opioid epidemic disproportionately impacts the Medicaid and Children's Health Insurance insured populations. So more than 1.5 million Medicaid members are living with an opioid use disorder, and that's probably an underreported value. Very tragically, Medicaid members account for nearly half of all opioid-related deaths in states that are hit hardest by the opioid epidemic, like West Virginia, Maryland, and New York. So Medicaid is ultimately standing there as the largest payer of substance use and other behavioral health treatments. So addressing these services and ensuring that there is equitable access to evidence-based care for Medicaid members is critical to resolving the opioid epidemic. So for folks in the room who might be less familiar, what do I mean by medications for opioid use disorder? We have 3 FDA-approved types of medications: methadone, buprenorphine, naltrexone. They're available in a variety of forms: tablets, oral, liquids, implants, injections, films. And again, there's a ton of evidence that receipt of medications for opioid use disorder is associated with reduced opioid misuse, reduced overdose, reduced mortality, and an increase in treatment retention and recovery. That said, less than half of adult Medicaid members with a diagnosed opioid use disorder access any medications for opioid use disorder, and less than 5% of youths who are insured by the Children's Health Insurance Plan receive medications for opioid use disorder. And for those who might be curious, these medications are approved for individuals who are 16 and older, save for methadone, of course, but there are options out there, but they're not getting them. So why is this happening? Well, I'm going to argue that underuse of medications for opioid use disorder is driven by a myriad of misaligned policy and evidence use behaviors across federal, state, and organizational levels. So let's start at the federal level. In 2018, we have the SUPPORT Act that essentially required all Medicaid plans to provide coverage to all types of medications for opioid use disorder by 2020. This sounded like a really promising federal policy. But then when you dig a little bit deeper, we find that the Support Act actually doesn't prohibit use of utilization management strategies like mandatory urinalysis or fail first policy step therapy that might limit access to these medications. Then CMS unfortunately publicly, very publicly said they actually cannot enforce Support Act mandated coverage because of poor reporting from the states. So this kind of looks like an unenforceable mandate. A lot of you study Medicaid in this room, and you know that state Medicaid and children's health insurance programs are allowed to design their own benefit arrays in ways that meet their state population needs. So there's a lot of wiggle room here. So states might not cover all of these medications in their benefit arrays. Medicaid and children's health insurance programs also contract with managed care organizations to administer their benefits. And I and others in this room have done research showing that managed care organizations really aren't always compliant with what the state Medicaid benefit looks like, right? So they might create more variation in access specifically to medications for opioid use disorder, and they might differentially impose restrictions on access to medications for opioid use disorder. What could some of these access problems look like? So it might mean that they're not covering all forms of medications for opioid use disorder. Then we might not see methadone in the benefit, for example, or we might not see naltrexone in the benefit. Some of my earlier research also found that some Medicaid programs and managed care organizations impose non-evidence-based utilization management strategies. So monthly urinalysis testing, and then when folks have a positive urinalysis showing that they have engaged in substance use, they are denied coverage of any medications for opioid use disorder. So this essentially constitutes someone with a documented need for treatment being banned from receiving the kind of treatment. That's obviously not evidence-based. Fail first and step therapy is a common utilization management strategy, and that prevents a provider from initiating treatment with certain medications that, until they show that the person has failed with treatment with others. So oftentimes you see injectable medications or implantable medications being withheld until someone is proven to fail on an oral or tablet medication. Dr. Grogan and her colleagues have also measured differential use of prior authorization across medication for opioid use disorder types, so differentially treating these medications. And ultimately, these practices, if they're not evidence-informed, right, they can increase risk of return to substance use, overdose, and death for individuals seeking care, right? And more importantly, they also conflict with client and prescriber treatment plans. So addressing this misalignment in medication for opioid use disorder policy and evidence-informed decision-making, I think, is a critical part of our response to the opioid epidemic. Here's just a quick snapshot of quantity or dosing limits on medications for opioid use disorder in all 50 states and DC. So for example, oral naltrexone or Revia has no limits attached to it in 33 states, but at least 5 states impose quantitative utilization management policies like annual or lifetime limits on prescriptions. And again, that could go against evidence-based prescribing practices. A great study conducted by Dr. Grogan and her colleagues highlighted differences in fee-for-service and managed care coverage for medications for opioid use disorder. The highlights are that state fee-for-service plans had greater access to medications for opioid use disorder, but more fee-for-service plans than MCOs imposed prior authorizations. And so ultimately what we're seeing is treatment planning for medications for opioid use disorder isn't just a discussion between the patient and their provider, right? The state agency, the managed care staff, they're sort of invisibly in the room shaping what patient treatment plans look like. So this brings us to some research in progress that I'm leading. This is a NIDA-funded study to address this sticky problem of the research to policy gap and increase policymakers' evidence use behaviors when designing benefit arrays for medications for opioid use disorder. Okay, so this study ultimately sort of at a high level really aims to identify the determinants and processes by which Medicaid and children's health insurance programs and MCO policy or managed care organization policymakers seek out, receive, and use evidence. The first aim, this is a national survey of state Medicaid, children's health insurance program, and contracted managed care policymakers who are involved in the benefit decision-making process. And the goal is to really understand their evidence use behaviors and evidence use preferences when they design medication for opioid use disorder coverage. And ultimately, the goal of AIM-1 is to yield a database that transparently describes the decision-making process across all Medicaid agencies in every state and territory. Then with AIM-2, because agencies are so different, right? Like if you study Medicaid, I'm sure you've heard the old adage, if you know one Medicaid program, you know one Medicaid program. So I want to make sense of this heterogeneity that we'll see, and we're going to use latent class analysis methods to identify hidden subgroups of agencies and organizations that kind of act similarly in their evidence use behaviors. And then the ultimate purpose of this is to use that information about each of those evidence use behavior classes and design tailored policy dissemination strategies to enhance their use of research in the evidence, use of research in the policy design process, ultimately with the goal of increasing more evidence-informed benefit arrays related to substance use treatment. So I'm going to break that down a little bit. That's the high level. So I promised we were going to talk about implementation and dissemination science today, and I'd be remiss if I didn't show you a theory, model, or framework because my field loves that. So here's a big one. And I think about frameworks as really roadmaps to help you understand the different competing demands and variables that you might need to consider in your study. And there's a lot for this one. Right? Why are these decisions not more evidence informed? What are the other factors coming to the table and influencing policymaker decisions? There's a lot. So this framework is going to help me. It really has been helping me conceptualize a little bit better. For those who are outside of the implementation science field, this is called the EPIS framework, and it gets its name from the process that it describes, the process of exploration, preparation, implementation, and sustainment. So basically, the exploration phase sort of occurs when policymakers in Medicaid or children's health insurance agencies and managed care organizations consider the need to change their benefit array for medications for opioid use disorder or change their utilization management strategies on these medications. And this marks the first time when a dissemination strategy could be deployed to promote the use of research in that decision-making process. Preparation phase then describes when policymakers' activities, addressing potential barriers and leveraging facilitators to roll out new policies around medications for opioid use disorder. And this is another opportunity to time the delivery of our dissemination strategies to influence benefit design. The implementation phase essentially describes when contracted providers start delivering medication for opioid use disorder benefits. And we can look for alignment or misalignment with evidence-informed policies during that implementation phase. And then sustainment largely focuses on continued coverage of evidence-based medication for opioid use disorders over time, as well as continued use of research in the decision-making process as a primary driver of those benefit decisions. I'm going to direct your attention to the blue circle on what should be your right. So this is the outer context in the EPIS framework. So this is describing the multi-level federal and state influences. So folks in leadership at the Centers for Medicare and Medicaid Services, but also the state governor and state legislature who can exert partisan influence over how Medicaid programs function. And folks, in this room have done really impactful research describing the partisan influence that governors and state legislatures have over their Medicaid programs and policy responses to the opioid epidemic. And my hypothesis here is that these influence persist over designs in medication for opioid use disorder benefits. The outer context also thinks about how federal and state policies are aligned or misaligned, right? So we talked about the Support Act. But something I've also seen in my work is, I did some work in West Virginia thinking about how they expanded access to medications for opioid use disorder in their Medicaid program. And while they had a very robust benefit array for Medicaid, what they saw was they wanted to increase access to methadone, but there's a statewide moratorium on opening methadone clinics in the state. So how do you increase access to methadone when you can't open any more locations to offer these services? Buildings are only so big, right? They can only see so many patients. So the outer context gets at that misalignment a little bit here. But it also considers funding, contract arrangements that can impact our service environments, perceptions and stigma, not only toward the Medicaid program, but toward individuals who use drugs, toward individuals with an opioid use disorder, and toward receipt of medications for opioid use disorder. But it also considers advocacy groups that could lobby for or against expanded access to these medications. And then finally, we're looking at how news and social media attention can also influence inner context benefit design decisions and policymakers' use of research. So I'm going to direct you over to the green circle, the inner context. And so this is sort of a multi-level context where I'm conceptualizing Medicaid and children's health insurance agencies, but also the managed care organizations that they contract with to administer benefits. So we see similar constructs here around leadership behaviors, organizational characteristics of the agency culture, like how much do they use evidence, how much do their supervisors encourage them to use evidence when making these decisions, and just thinking about how they consider the research to policy gap a little bit more. Innovation factors, that's in yellow at the bottom, that characterizes the different medication for opioid use disorder benefit policies that persist, including which types of medications are included in the formularies, generics versus brands, oral versus injectable, things like that. And whether they're available equitably to adults and children, or do we see different benefit design for youth members versus adult members of Medicaid? An important construct here is policy fit. So this is the use of evidence in the decision-making process, or sort of the policy transfer of the Support Act requirement to cover all of these medications into the state benefit, right? Do we see that policy transfer start to occur, or is it being halted by something else? And then finally, I promise we're almost done with the framework part. Bridging factors is in the red circle at the top. And this is kind of a novel part of the UPUS framework that I really like for policy studies, although it's been underused in policy work, so you might find it useful. But bridging factors basically acknowledge that there's often something missing to align the inner and the outer context, right? How does leadership, how do they differ across these contexts? What are their priorities, their competing demands? And so bridging factors thinks about how can we better align outer and inner context. And I'm going to argue in this study that dissemination strategies can serve as bridging factors here. So bridging factors could be trusted intermediaries who deliver information to policymakers, right? Folks in their policy network, and hopefully researchers like us, we can live in that space. Bridging factors can also be formal arrangements or collaborations between policymakers and researchers, like expert panels or work groups that are sometimes, hopefully, consulted when benefit design is revisited. But it's also about information sharing processes. So what are we putting in policy briefs? Because I promise they're not reading the journal articles we write that are behind paywalls, right? How do we communicate? When do we communicate? And what information are we sharing when we engage in that process? And hopefully throughout this study, we'll also identify other novel approaches to the targeted distribution of evidence about the effectiveness and need for medications for opioid use disorder in benefit arrays. So we can do a little bit of a deep dive here in the remaining time. Aim one of the study, as I promised, is to develop and administer a national survey to all state Medicaid and children's health insurance programs, as well as those programs that operate in DC and the territories, and to all of the managed care organizations that they contract with. And the goal here is to identify the determinants, the mechanisms, and intermediary characteristics that influence these policymakers' behaviors seeking out, receiving, and using research to define their benefit arrays. So this is really kind of two surveys here. The first is kind of a factual survey, just basically confirming what they do cover, which medication types, what's on the formulary and the preferred drug list, and what kind of utilization management strategies are being applied to each medication. Is it prior authorization, reauthorization, step therapy, things that we mentioned earlier. And then the meat of this, and really the heart of the study, is the second part of the survey, which is about the evidence use behaviors. So understanding what type of, how often do they revisit these benefit decisions? Sadly, a lot of research has shown that sometimes Medicaid benefit arrays don't change over the course of a decade, but we know science moves faster than that. So these web surveys are going to staff at all Medicaid and children's health insurance agencies across all of the states and territories, as I mentioned, and also to the MCOs. And there's probably about 260 managed care organizations last time I checked that are contracted to administer these benefits. So this is hopefully going to be a robust database, but that is not without its own challenges, which we can talk about. And the key respondents of this survey are agency leaders. So not necessarily the Medicaid directors, although they'll certainly be outreached, but I'm thinking about the medical directors, behavioral health directors, pharmacy benefit managers and staff, and others engaged in these decisions about medications for opioid use disorder coverage. And then the idea here is to essentially aggregate all of these individual level survey responses within each agency or managed care organization to the organizational level, so we can understand how the organization is functioning. What is their evidence use culture like? And so we'll be using agencies and managed care organizations as the unit of analysis for the survey data. And that's really with the goal of designing dissemination strategies that are tailored to their agency or tailored to their managed care organization's behavior, rather than to the individual needs of different staff members that might have varying roles, responsibilities, influence, and who might turn over the next year or so, right? And this also prevents us from deploying conflicting dissemination strategy messages to colleagues in the same agency or organization. So this is kind of a fun slide, and I will be taking feedback on this. So I'm toying with the idea of calling this the Policy Wise survey. And there's a very sad PowerPoint-driven logo created for this. So anyone who has more graphic skills and clever acronym titles, feel free to offer your suggestions. But here's a summary of some of the questions that we're looking to ask. Do Medicaid and children's health insurance programs share leadership and staff, or are they really different organizations with different evidence use behaviors and implementation climates? How is the Medicaid director selected? We see in a lot of states that sometimes these are folks who are appointed by a governor, and so they might be appointed to carry out a political agenda around Medicaid benefits. In other cases, they just might be sort of street level bureaucrats, right, that rise through the ranks over time and assume these positions. I'm also curious when legislative approval is needed in some states, because that does differ. And so even if the Medicaid agency wants to create a very robust evidence-driven benefit, how might legislative approval change that or impact what they're actually able to pay for? And how often are they revisiting these decisions? So that's a bit about the agency characteristics that we'll use as indicators for the latent class analysis. But again, the heart of this is about the evidence use behavior. So here's just sort of short versions of some of these questions. How likely are you to use information from a variety of sources? And so we'll ask about personal knowledge or colleagues, an academic researcher, advocacy groups. How often are those sources of information consulted when benefits are designed? And then what type of information they're using, work group recommendations, data on cost effectiveness for the medications, things like that. And then how likely are they to use information presented in different formats? And this is going to get at how they want to receive information, right? So do they want to see policy briefs? Do they want something more interactive like a workshop or technical assistance or expert testimony? What's the best way to reach them? Because again, we know that they're not reading journal articles. And then there's also some items here from the Research Dissemination Barrier Survey, which essentially gets at why they might or might not use research, their capacity to use research in a meaningful way. And also there's a 6-factor model of evidence-based decision-making scale that measures some of those items as well. An important component of this is stigma, right? Because we know there's a lot of stigma, not only toward Medicaid, folks with opioid use disorders, but also receipt of medications for opioid use disorder. So there are some questions in the survey about their belief that medications for opioid use disorder are safe and effective and helpful for recovery. We'll also ask some questions that get at some of the stigma, right? So something I hear a lot from policymakers is, isn't providing methadone just replacing one drug with another? Which obviously the evidence says like this is not true. This is treatment in and of itself. But so we need to get at that so we can understand what type of information we might need to start coming to these policymakers with. And then finally, there are some questions from the implementation leadership scale. And this really gets at how knowledgeable and supportive is your supervisor or the leadership in your agency for the use of evidence-informed decision-making. So as I mentioned, I'm expecting to see a lot of variation in this national study, right? Again, if we know one Medicaid agency, we know one, they're all super different. And doing a study of all 50 state agencies plus DC and 5 territories, no doubt we'll see even more heterogeneity. So latent class analysis is the approach to deal with this problem. So this is a finite mixture model approach that moves beyond those differences to identify and classify agencies or organizations into subgroups or latent classes based on patterns of responses to some of the key observed inner and outer context and bridging factor variables that we went over. And again, latent class analysis is really cool because, right, it maximizes homogeneity so that folks in the same class are as similar as possible, while also maximizing heterogeneity between the classes to ensure that the classes are indeed mutually exclusive. And so some of the probable indicators we'll be using for this is the need for legislative approval to change benefits, partisanship measures, to see how that influences benefit design and coverage, agency structure, and of course the decision-making behaviors and preferences, as well as implementation leadership and preferred intermediary types. Who do they trust to get information from? But that part of this is exploratory, so we'll see what happens there. You know, I think this is interesting because something I'm expecting to see with this latent class is that Medicaid agencies and their contracted managed care entities might actually be in different classes and might have different evidence use behaviors and preferences that we need to address. And so I'm expecting to see some sort of misalignment between those preferences and evidence use behaviors. But that's cool because once we measure it, we can do something about it and design dissemination strategies in a way that's really meaningful. The other really nice thing about using latent class to identify these groups is that it allows for unanticipated classes to start emerging in the data based on observed determinants of their evidence use, rather than me as a researcher saying, I know what the most important indicators are, or I'm going to group them in a way that makes sense to me, right? I'm taking my assumptions out of it on some level. So for the latent class analysis, we'll be doing some descriptive summaries to describe these latent classes, and that will hopefully be useful information for not only developing tailored dissemination strategies, but also just helping us as researchers understand the different evidence use behaviors out there. And in order to validate that these are real classes that really do exist, I'll be sort of presenting the latent classes and descriptions of them, their preferences, what makes them in that one class versus another, to a small group of Medicaid policymakers to get their feedback and tell me, hey, are these, you know, does this look familiar to you in your experience working with these agencies? Does this look like you and your colleagues? And then all of this sort of culminates in designing adult and youth class specific policy dissemination strategies with the common aims of facilitating evidence exchange between agency and managed care policymakers and research-driven intermediaries, sort of overcoming some of the noise of other intermediaries who might not be as evidence-driven. And ultimately, of course, promoting the uptake of evidence-based benefit arrays that include all medications for opioid use disorder with evidence-informed utilization management strategies. And so we're using this sort of 10-step process that I developed with my team to develop and specify the strategies, and I'll show you that on the next slide in case it's of interest. But once those strategies are developed, we'll be pilot testing these. And so we'll identify one agency or managed care organization from each latent class in AIM 2 and ask them to participate in the pilot study, testing these tailored dissemination strategies. So each participating agency or managed care organization will be assigned strategies tailored to their class and strategies that are tailored to other classes. So the idea here being they'll be receiving matched and mismatched strategies based on their own evidence use behaviors, with obviously the goal being that the matched strategies work a lot better than the non-matched strategies or the mismatched strategies. And I'll be asking these policymakers to complete some survey questions evaluating the acceptability or satisfaction with the content that's put in those based on what we learned from the latent classes, preferences, the appropriateness of the dissemination strategies. Are they relevant? Is the information provided in them useful? Is it timely? And what's the feasibility of these strategies? Meaning, how practical is it to use evidence from them in their everyday policymaking behaviors? So here's sort of an overview of our process for creating tailored dissemination strategies. And this is sort of a lot to look at on a table. And I know there's a big glare coming in from these wonderfully bright windows. But essentially, we want to think about how do we, identify the message target, if we find in an agency that a lot of their benefit design choices are driven by cost, then cost needs to be the thing that we focus on when sharing information about medications for opioid use disorders. And then we'll look and see if that message target, right, is it aligned with the research that's happening right now? We'll think about what's the outcome that we want to change. Obviously, it's benefit design if it's a non-evidence-based benefit, and then think about, how to present this research to folks. What's the preferred source of evidence to receive it from? What kind of messaging? How can we make it a data-driven, evidence-based message to help inform their decision-making process? And specifically, who should receive this message? Which person is making the decision? Is it a medical director? Is it someone else? Is it a few people? And then also, thinking about how they want to receive this in terms of, is it a research summary? Is it an issue brief? Is it a short email communication? Is it technical assistance? When do they want to receive it? How often are they revisiting benefit designs? When does a policy window open so that they can actually address this? And think about, how often not only when do we deploy this, but how often we deploy it over time. Do they need it once? Do they need it multiple times? So hopefully this study will address some of the black box policy making that is prevalent in Medicaid benefit arrays, and it'll illuminate some of the key determinants, mechanisms, and intermediaries or purveyors of information that these Medicaid agency and managed care policymakers trust to receive evidence from. But it'll also help us identify ways to reduce the research to policy gap by designing tailored dissemination strategies, right, that generate knowledge about how we should be better communicating our research to policymakers and when we should do it and in what ways. So I'm going to wrap up by sharing a couple of takeaways, right? We covered what is dissemination and implementation science. Typically, it hasn't focused on policy level factors too much, but I think that that's sort of a misstep on our part as implementation scientists. There's a lot that we can learn about policy implementation research from political science and public administration scholars. But what we can offer is also thinking about how to design, tailor, and test strategies that promote the implementation of evidence-informed policies and also promote the use of evidence in decision-making and policy-making processes. I also think that policy-focused D&I strategies can probably help us address the research to policy gap. I'm curious for your thoughts on that. We talked about a really sticky problem, really effective research that medication for opioid use disorders work. Sometimes evidence-informed, sometimes less evidence-informed policies, but nonetheless, this misalignment leads to inequitable access to medications for opioid use disorder, and this is very dramatically shown in the Medicaid program. But hopefully, targeted dissemination strategies can promote evidence-informed policy designs and ultimately more coverage of medications for opioid use disorder. So I'll stop there. Thank you so much for your time today, and I welcome any questions and feedback. Yeah.
Do you want to just field questions?
Sure.
Okay. You have a couple right here.
That's great. Yeah, go ahead.
As your research evolves, how that player or that piece of the framework plays into it. Just knowing, for example, that a lot of patient populations that have these types of disorders also have larger social complexities that inevitably spill over into other state agencies beyond Medicaid. I'm particularly thinking of what CMS just announced yesterday around justice populations and kind of the continuity of care across justice facilities into the community. I just foresee a dimension there of like not only like what's listed as a benefit under Medicaid, and then what's covered under the utilization management of MCOs, but like what is even available in a facility, and how do you rectify those two? Obviously, we're very new at that, but I'd just be curious on your take as this unfolds, like where you potentially seeing that, and that's just like one population that could be considered.
Yeah, that's a fantastic question and a very hard question to answer. So yeah, we are considering how Medicaid agencies work with other state agencies that are influenced by them, and who foots the bill for a lot of these services, right? So we know in some states, Medicaid agencies stand alone. In other states, they're part of a larger Department of Health, right? And they're one department or division within that larger health authority. So it'll be curious we are going to measure, how often they work together, what kind of information they get from these other state agency actors to inform their decision-making process. So that'll help us start to understand that dynamic a little bit better, because a lot of states have traditionally been siloed, but they're moving toward more integration and coordination of services. I'm curious, part of my research focuses on the criminal legal involved population because there's a lot of crossover. These folks are usually eligible for Medicaid as well. And so I'm really curious about the evidence use behaviors for folks involved in the Department of Corrections, right? How are they and their perceptions of medications for opioid use disorder influencing access to those medications in jails? Because it's not just about logistics. There's a lot at stake there to unpack. And so I've been thinking about that too as a potential, next part of this project. Yeah.
Former Medicaid administrator who was stuck in that dilemma a lot, and not a lot of people were thinking about like because of expansion, our populations were now coming from previous safety net systems that we were not speaking the same dialect, if you will, and we were causing some pretty potent disruptions in care, and it was just the tip of the iceberg. So I know it's a hard question, but I would say like it's going to be really helpful in the future. And then along that lines of your second comment, I'd just be interested to like around your thoughts on just stigma too, because inevitably if you think about a state that designs a benefits package, right, like it's a function of the political environment of the state. And so how does like the community stigma around behavioral health writ large influence political structures, which then influences like whether or not some of these benefits are even covered.
Yeah.
And so to your point, like even the serviceable population, the end user and their own stigma, how it shapes their interaction of that system, I think is a pretty, for lack of a better phrase, pretty pregnant area of like, you could go into a lot of different areas and pack it. But overall, this was amazing. And as a Medicaid administrator, I'm like, this is very timely. So thank you.
Thank you so much.
Hi, thanks so much for this really interesting talk. I'm wondering a little bit about how you think about addressing gaps in what maybe end up being, policy or practice mandates. So I'm thinking specifically about there's a law in the child welfare space called the Family First Prevention Services Act that mandates the use of evidence-based practices. But even in the case where you have a mandate, there's still kind of an organizational gap between frontline practitioners who maybe you're supposed to ensure that patients or clients have access to a specific medication or a specific service, but the fidelity to that is much harder to track at that frontline worker level. So I'm just curious how you think about that. If we're moving in a direction to really encourage this policy and evidence-based practice connection, what do we then do about the frontline workers who are in charge of giving these services or these medications to actual clients?
Yeah, another totally fantastic question and complicated, sticky problem for us to address, right? So that's a really strong argument for multi-level implementation strategies or multi-level dissemination strategies. I think that And largely our field is pretty good at the multi-level part of it, right? It's hard to address everything in one research project. But there's a case for coordinated efforts where, you can change how things look at the federal and the state level, but you need to be changing how things look at the organizational level and points of service, as you mentioned. And so I think that as a field, we need to definitely wrestle with that and think about how to do this in really coordinated, well-timed ways, because we can't fix one part without fixing the other. That just it shifts the misalignment, essentially. So yeah, it's not something that this study is particularly focused on, and largely I didn't focus on addressing that in this study because there's a wealth of other studies, especially with the wonderful J-Coin initiatives and HEAL initiatives out there now that are focusing on improving access to evidence-based substance use treatment and the whole care continuum within provider organizations. So I'm letting those folks do that work, but definitely keeping my eye on it. And there's a fantastic researcher at Oregon Social Learning Center named Gracelyn Cruden who is dealing with the Families First problem very closely in her research as well.
That's great. Thanks so much, Erika. This was really, really interesting. I have a ton of questions, but I'll ask just one of them. So one question I have is kind of in response to the disjuncture between, your main argument, right, that there's a huge misalignment between evidence-based research and policymakers. And one example you gave, and there are lots of reasons for that. And one reason is the way that researchers focus on outcomes is not the same as how policymakers might want to focus on outcomes. So the example you gave is, researchers might focus on costs and policymakers want them to focus on cost effectiveness. And so that all makes sense to me. But then I started feeling a little bit uncomfortable at some level of sort of like, how much do we just feed into what policymakers want if we think what they want is sort of a bit narrow, or they're defining the problem in ways that ultimately are not helpful. And so one example I have from quite a long time ago, but I think it might be a good one, is the Medicaid expansions in the 1980s really focused on pregnant women and children, pregnant women and infants, and pregnant women and children. And the whole argument at that time was that it's very cost effective to expand services to pregnant women and infants and children because of the high infant mortality rates, especially among women women and kids of color. And that evidence, I think, did lead to incremental expansions in the 80s, and then, ultimately, I think, led to SCHIP and what CHIP today. And so on one level, that's a really good thing. But it did create this kind of embedded discourse in Medicaid that you should expand the program kind of small incremental population group by population group, only according to that which is cost effective, right? And you might argue we should, as we eventually did with the ACA, but still many states are resisting this, that we should expand coverage because everybody deserves a right to healthcare, right? So we kind of fell into that discourse when maybe in the long run, falling into that is not all that helpful. So just wondering, what do you think about this larger agenda in terms of trying to change the discourse? Like, do we fall prey to only operating within an incremental, kind of more narrow discourse? And what do we do about that? That's a big question.
It is a big question, and I appreciate you asking it. That's sticky. Yeah, it's a real tension. And I agree. I think that some of these previous policy expansions have really led to inequitable access to care across the different populations that Medicaid serves. What also comes to mind is when that doesn't work too. Like, we see a lot of states that initially, when there was the 1115 waiver opportunity to provide a robust substance use disorder treatment care continuum, a lot of states embedded a justice population or criminal legal involved population specific approach And then it was funny when I did research studying the implementation of those 1115 SUD waivers, I kept asking states like California, like, so what happened to the initiatives focused on the criminal legal population? Like, where'd that go? What do those benefits look like now? And they were like, that kind of like fell off our focus because we had to deal with other problems. And so I think that'll be a state by state problem that we have to look at in the data for sure. Like, what are the outcomes of interest and how do those outcomes of interest compared to what their current benefits look like? Are there already existing inequities that these outcomes that they're interested in might sort of exacerbate, or might those outcomes help address some of those inequities? Like, are they looking for more social determinant oriented evidence around the need for medications for opioid use disorder, or are they just focused on the cost? And are they going to use that as a way to only cover the cost of these medications for pregnant women, right? It'll be something to definitely take a look at. And that's partly why I designed the project to separately ask about coverage questions and evidence use behaviors when they think about adult versus youth populations who are covered by Medicaid or CHIP, because I am curious and suspicious that those inequities exist as well.
Thank you so much. I'm curious if you can speak, like if you've seen in your research, so your project seems to be more focused on like state policies and like asking states individually, and then as you said, making like the 3 groups and then having different targeted approaches based on that. And so I don't know if you've done, or like basically in your research, like the balance between the federal policy and the state policy, if you feel like, you know, if there's a harm of having a federal policy because a blanket approach might like be inequitable based on the different needs that states have, versus, you know, having, if you have a federal policy, then it'll be more like in terms of changing the narrative and getting these things pushed forward, it'll be like more helpful. So I know there's like a balance there, and I don't know if you could speak to any like research you've seen in that.
Yeah, so we're touching on the very complicated and interesting problem of federalism, right? Which folks in this room are experts in. Yeah, it's a great question, right? Because Medicaid is a joint federal state administered program. Something like Medicare is federal administered program. They're both public insurance programs, but they operate totally differently with different influences. Yeah, so does making the state Medicaid benefits does increasing the uniformity around coverage of medications for opioid use disorder across every state Medicaid and CHIP agency create problems for tailoring to the needs of the population? It's an interesting question. You know, I would argue that medications for opioid use disorder are a first line treatment for opioid use disorder, and the research shows that they are as effective without outpatient therapy as, you know, with outpatient therapy. So it's really about how do we create access to them in the midst of an opioid crisis where people are, like I said, we're losing our friends, our family members, and our neighbors rapidly. And COVID exacerbated that problem. And so creating more access to this life-saving treatment, even if, you know, it creates uniformity and access to it, like I would argue that that's a good thing. And I'm not terribly concerned about the federalism piece of that and state decision-making processes. You know, I think ultimately state benefits won't look the same no matter what we do. I think that they'll differentially impose utilization management strategies that might make sense for their populations, right? So, and we can get into the specifics of that too. That's kind of a longer conversation. But I don't know, I'm not terribly concerned about that uniformity when the idea of it is to save lives and make sure that people at least have access to coverage of these evidence-based medications, right? Ultimately, it's the decision of the patient and their provider what their treatment plan looks like and what services that they can access. My goal is to just make sure all of those options are on the table to them when they engage in that treatment planning process.
We have some online questions.
Sure.
Adam Scheffler asks, what is the anticipated usefulness for changing decision makers' behaviors or producing different outcomes than we see now and have seen for 30 years? Also, even with positive results, how will those outcomes be diffused across relevant actors and organizations?
Okay. So, yeah, I mean, I think the idea is to figure out, we don't have a lot of transparency in the Medicaid decision-making process. There's some work on that, but not around benefit decision-making processes necessarily, at least not as much to really get down to the nitty-gritty of who's in the room when these decisions are happening. And also, how do we create the room where they happen and that they're revisited, right? Because a lot of our benefit arrays are outdated. And so I think the goal with this study partially is to figure out where those rooms are and who's in the room when it's happening, essentially, right? And start to figure out how we can change their decision-making behaviors in a way that just creates options for access to evidence-based treatments. And I think if I'm hearing that question correctly, Keith, part of that was, do we think this will really work? That's a fair question, and arguably the point of science too, right? Like, we might think some dissemination strategies might be more effective than others, but the point of the latent class analysis here is to take me as the researcher and all my assumptions out of the process and say, what do the data show us empirically, how these dissemination strategies should be tailored to the needs of these policymakers? Because I would argue that I don't think we've been doing a great job over the last few decades of research in terms of figuring out how to reduce the policy or the research to policy gap. So hopefully this alternative sort of empirically data-driven approach helps to get at that in a more effective way.
Thanks, Colleen. I've got 3 questions, but I'll only ask one.
Okay.
Traditional medicine has been dealing with this issue of dissemination forever. And in the last 2 or 3 decades, there's been more focus on it in terms of best practices and all. Is there a body of research you can draw on that you can learn from when you're trying to disseminate issues like opioid use treatment? And because there's been so much that's going on, including in the pharmaceutical industry, doing direct to consumer advertising rather than trying to go through physicians to get medications prescribed. So is there something we can learn from that? Is there something out there that you can learn from? And
yeah.
and because it's an old problem in medicine. It's been there forever.
Yeah, this is a great meaty question. So yeah, okay, so dissemination and implementation science is a more recent sort of growing subfield within health services research, but as I mentioned, it's interdisciplinary, and we have a lot to learn from the disciplines that gave rise to it, right? And some of those disciplines include political science, right, which they've looked at how citizens and policymakers engage and put values on different policies, and sort of ultimately how those policies get shaped by, and what makes them more effective in terms of getting passed and things like that. Public administration has also done a lot here, but I think the communication fields have a lot to offer as we think about how to effectively design dissemination strategies. And of course, like you said, we can look at effective marketing campaigns by big pharma companies as well. It's interesting, you mentioned how pharmaceutical companies often go to direct-to-consumer marketing, and that's been a challenge in Medicaid, right? Like, there's a fantastic book that really piqued a lot of my interest in Medicaid policy issues that Dr. Grogan wrote, Unhealthy Voices, Unhealthy Silence, and it talks about the absence of advocates, in the room when people don't speak up. And so I am concerned, right, if we do start to focus on, if we designed a study where we were focused on encouraging Medicaid members to speak up and advocate for their benefit arrays and things, like how effective would that be? That's a great question. Someone should study that. I think Jamila Mishner does a lot of that kind of work. And there's certainly a lot to learn from there as well. So yeah, there are definitely many disciplines to draw on, a lot of great work in this space.
Something that direct-to-consumer advertising. Can you hear me? There is the role of the power of the people that you're reaching. You know, if we're talking about cancer care, consumers are really quite powerful, and in fact, a lot of what we're trying to do in implementation science or comparative effectiveness is to restrain ineffective therapies that patients want, that there's a lot of political pressure to pay for, that are not effective. And I just wonder how implementation science would look different if you had a population that was fundamentally more powerful, less stigmatized, more socially influential. Because, you know, it just seems to me it's fundamentally different enterprise.
I think
I
that's
thought that was going to be a question at the end of that, but as I was saying it, it sort of sounded more brilliant before I said it than after I said it.
It's a great comment nonetheless, Dr. Pollack. I agree. I mean, I think that's why, you know, it's funny when I talk about my research at some conferences, I get weird feedback. I'll call it weird. I'll put that value judgment on it. You know, I'll hear take the politics or the partisanship out of this translation of evidence-based practices in our healthcare systems. Like, we're not advocates, we're researchers. Why are you dealing with partisanship issues? Or, you know, are you really over, how many questions do you need about stigma? And I think that whenever you're talking about access, you know, any kinds of services for individuals who use drugs, that's one level of stigma. And then when we think about access to medications for opioid use disorder, that's another level of stigma, right? Because a lot of folks in the treatment community might consider that not treatment, right? Like, we see a lot of barriers to folks joining NA or AA groups because folks in those settings will sort of say, well, that's not sobriety, there's another medication in there. And then when we think about Medicaid, gosh, there's no shortage of stigma. How deserving are people for healthcare services? How deserving are they of publicly funded insurance? I would argue everyone is deserving of it, but there are so many levels of stigma. So you're right. What would it look like if these were not the contextual factors at play? Yeah. Mm-hmm. Yeah. Well, I think it stems from a moral judgment that people shouldn't be using drugs, right? Or they shouldn't be accessing free healthcare, right? Whereas cancer, whose fault is that? Whereas substance use disorders, even though we can stay here in this room and know that substance use disorders are a chronic disease, other people might disagree with that. I agree.
This conversation, it relates to a question that I had, which is, you know, cost effectiveness sounds like objective, pure scientific research, but we know that what you count as effectiveness, just as Harold said, depends on whether you're counting effectiveness only to the patients or if you're thinking about the broader society or both, and all the other things that go into that bucket of value, right?
Yeah.
And then similarly, you know, what gets counted on the cost side. And so there's a ton of assumptions underlying cost effectiveness research that really is just about our values, right? Like, what values do you bring to the table? And so I was curious, you know, we can call that evidence-based research, and it's important. It's a very important research, but do we lay bare exactly what the assumptions are that underlie the different models so that we're having a very transparent conversation with policymakers? You know, kind of how do you approach that from a dissemination perspective, right? Or do you just say it's always cost effective and forget kind of getting into the details of what underlie the models? Yeah.
Yeah, that's a fantastic question. Okay, so I'm going to preface this answer. This is a great question. This is a great topic. I'm not an economist, so I'm going to put that out there. And cost effectiveness data is one option of, we think policymakers care about that, but there could be a lot of other outcomes that they care about, and I'm hoping that they do, because again, I'm not an economist and I don't want to keep doing cost effectiveness studies. So there's a lot of options that we could present them with, hopefully, for outcomes that matter to them. That said, it's funny, I've been having a lot of one-on-one conversations with Medicaid medical directors about this project, just to sort of gauge, take the temperature of like how interested are people going to be in responding or participating in this study. And it's funny, they say things, these are medical directors, so consider the sample, but they're sort of saying things like, gosh, I don't know, like maybe cost effectiveness data will be important, but also I think there's an argument that health economists should kind of get out of healthcare, because we see a lot of economic arguments in the substance use space that are unproductive, right? There's a very famous paper that I won't give the name of because I don't want to give it more publicity, but it came out kind of, some economists evaluated the utility of naloxone, which is opioid overdose reversal medication, and they described naloxone parties where people intentionally overdosed because that naloxone was available. That's, of course, totally false. And that paper has a lot of problems and was ultimately, it was recalled and then it was edited. There's a lot of issues there with that paper. I think some folks are nodding. You might know what I'm talking about, right? So there's an argument about like what outcomes to present and the assumptions that go into any model, how you're evaluating what is cost, what is effectiveness. So I think, yeah, as researchers, we need to be transparent about our assumptions. And I think there's also a case to acknowledge that anytime we're advocating for an evidence-based practice or an evidence-informed policy, we're asserting a value judgment there that these things are more important to fund than something else, right? There are no politically neutral health interventions, because funding one thing versus funding another is prioritizing. So I think there is something about that. I do think researchers also probably haven't done a great job being transparent about the values that they bring to their research. And there's this hesitancy to acknowledge that, because we say, oh, well, that makes us look like advocates, or that makes us look like we're somehow less rigorous or unbiased. I still think that we have a lot to learn. We could, draw on the anthropology and sociology fields where they talk about their researcher perspective and researcher assumptions and positionality in their papers, right? And how that brought them to the research question, the hypothesis, and the variables that they measured. I think that we could do more in copying some of those methods and using it in our work to address the values that we bring.
Yeah, there was one more question online. When policymakers need to make decisions fast, what strategies would you recommend to speed up the process without compromising quality? Still stay evidence informed.
Yeah, that's a great question. So hopefully we find, hopefully the latent class analysis and the survey data show us what some of those strategies should or could look like. There are things like rapid evidence review. So I'm not sure if anyone is familiar with the McMaster Forum. It's a Canadian-based institute, and they're really great at they're a WHO-funded institute, and they're really great at doing rapid evidence reviews and disseminating them to policymakers during the legislative session when they need information. So I think it's about being nimble, but I think in order to do that in a really rapid way, it's also about building those collaborations and building trust up front so that you are getting the request for information as soon as it comes up and is relevant to the policymaker decision-making process.
When you were mentioning the policy briefs as potentially a mechanism to engage policymakers directly, I'm wondering who would be writing those, if that would be like researchers that have policy experience or members of their team, or partnering with an external maybe organization to help write those memos or briefs to allow for this more fast dissemination of research, and also to bridge that partnership to have more of that back and forth, what's useful for both parties in those partnerships.
Yeah, I think any of those options, it's a great question, Caroline. Any of those options could be relevant, right? So policymaker, if policymakers are saying they want policy briefs, we have to have researchers who know what a policy brief really is, and they know how to write one effectively. Because I see a lot of policy or researchers say, oh yeah, I wrote a policy brief and it's like 5 pages long. And I'm like, what is that? I don't think that's brief, and I don't know what policy that's going to inform. So I do think that researchers probably need the skills to write a policy brief in order for that to happen. And so then the idea becomes what organizations might be well positioned to do this and might have expertise in doing this, and can they work with the researchers to understand, interpret, and synthesize the research, but then communicate it more effectively. And we see that all the time, right? That's not different than if you see an op-ed in any newspaper that's written by a politician. I guarantee they didn't write it. There was a ghostwriter, a team that helped them write it with their ideas, but just communicating it in an effective way to that audience. So I think the same could happen here for policy briefs. Thank you so much.